So good morning, class. So for this morning, we are going to discuss the physical examination of the head and eyes. So at the end of the class, you guys should be able to review the anatomy and correlate with the physical examination and be able to perform physical examination of the head and eyes, no? With the exception of the fundoscopic examination. So we'll just have a brief review of the anatomy of the head. So the regions of the head are named after the bones under the underlying bones, no, underneath that area. So for example, if it's overlying the frontal bone, it's called the frontal area, and so on and so forth. So the landmarks that you will see in the head would be the parotid gland here. So in front of your ears. And usually if it's swollen, like for example in mom's parotitis, or you have a tumor in the parotid gland, it will be palpable in this area. Next, you also have your submandibular gland near the mandible, and you can actually feel it if you tense the muscles in the floor of your mouth. No? So those are your sources of your saliva. And next, there you could also see the superficial temporal artery, no, in front of your ears here. In patients who are very thin, no, emaciated, or have temporal muscle wasting, that's actually very prominent in this area. Okay. So you have your vertex, you have the parietal area, the frontal area, the temporal area, and the occipital area. Okay. So the eyes, particularly this area, no, the area between the upper lid and the lower lid is called your palpebral tissue. No? And then the thin film that covers your sclera is called your conjunctiva. And you have your conjunctiva in the palpebral, so that's the one covering your sclera, and your bulbar, and that's the one, the bulbar is the one covering your eyes or your sclera, and the palpebral conjunctiva will be the one covering the lower lids here. That's your palpebral conjunctiva. This is your medial canthus, lateral canthus, and then of course your iris. And the sclera meets your iris through this area called the nimbus. Okay, so your eyes are covered by a thin film composed of thin film, no, with tear fluid, and the three sources of tear fluid are your meibomian glands here, no, you can see that more clearly looking sideways, the conjunctival glands, and the lacrimal gland. And the lacrimal gland is seen in the upper lid, in the lateral aspect of the upper lid. And then the tears are drained in your lateral puncta and down to your lacrimal sac, into your canaliculi, down to your nasolacrimal ducts, where it completely drains the tears or secretions coming from the eyes. Here you can see also your iris, no? The iris adjusts the size of the pupils. It makes it bigger or larger. And the ciliary body here adjusts now the thickness of the lens. And if you cut the eye into section like that, no, you will see the anterior chamber and the posterior chamber. And the anterior chamber and posterior chamber is filled by a clear liquid called the aqueous humor. This is your retina, your choroid, your sclera, and there's of course your lens, your pupil, the iris that controls the diameter of your pupil. And when you look into the posterior portion of the eye using your ophthalmoscope, you will be able to see the fundus. This is called the fundus. And the optic artery and the retinal vessels come out from the posterior part to your fundus here in your optic disc. Okay, your optic nerve, your retinal vessels, optic artery, and vein. And in the medial side would be your macula. So I think it will be ophthalmology that will be discussing the fundoscopy of the eye. So we'll just describe briefly the different reflexes in the eye, the pupillary reaction. You have the light reaction, no? So when you shine a light in one of the eyes, the impulses are transmitted to the oculomotor, to the optic nerve, and then to the visual cortex, and then the visual cortex now sends a signal to your oculomotor nerve to constrict the pupils, to constrict the muscles of the iris so that the pupils will constrict. So when you shine a light in one eye, so from dilated, and it now will constrict because of the pupillary light reaction, that's called your direct reaction. But if you look at the other eye, you will also see a consensual reaction. Even if you don't shine a light on this eye, it will also cause a constriction of the contralateral pupil. So this is how it happens. So when you shine a light here, it will send a signal through your optic nerve, to your optic tract, and then to your visual cortex, and then the visual cortex will send a signal to both oculomotor nerves to constrict the iris and constrict both pupils. So the one that you shine your light on is called the direct reaction, and the contralateral eye, the one that you did not shine a light on, will be your consensual reaction. Another example of a pupillary reaction is your near reaction. So when a person shifts gaze from a far object to a near one, the pupils will constrict. So that's the reaction of the pupils. So for example, let's say this object, if this object moves towards me, if you look at the size of the pupils, it will constrict, But at the same time, when you do that, that's called the near reaction, the constriction of the pupils when you move your gaze from far to near. But at the same time, if you do that, you will also observe convergence. Now, convergence of the eye is an extraocular movement when the eyeball will move towards the medial gaze, both of them. And accommodation. Accommodation is when there is an increased convexity of the lenses caused by the contraction of the ciliary muscle. So how do you do that? You hold your finger, if you're the examiner, or a pencil about 10 centimeters from the patient eye, and you ask the patient to look alternately at it into the distance directly behind it. And then you move it towards the near and watch the reaction of your pupil. So you can test this on another household member in the house. So you can practice. So you can actually see for yourself the different pupillary reaction. Next, we go to your extraocular movement. So there are 6 cardinal directions of gaze as shown here. So here, 1, 2, 3, 4, 5, 6. So each movement is controlled by 2 muscles. So for example, you want to move your gaze downward and outward, you will have to contract your inferior rectus in this side, and also your contralateral superior oblique to move the other eye. So that's your conjugate eye movement, If one of the muscles is paralyzed, let's say your superior oblique is paralyzed, the eye will deviate from its normal position in that case of the eyes, and the movement will no longer be conjugate or parallel. So if you move your eye downward and outward, or downward and rightward, it will be, let's say this one is paralyzed, so superior oblique is paralyzed, it will only be the right eye that will move, no, to the desired direction, but the left eye will not move. So their movement is no longer conjugate. So those are called the conjugate, the movements of the eye. So if you look upward and leftward, it will be your superior rectus that will contract and the inferior oblique muscle that will contract on the contralateral eye. So when you do the health history of the patient, the symptoms, the common or concerning symptoms for the eyes and for the head will be number one, your headache, of course, for your head, and any changes in vision, double vision, or diplopia. So one of the most common complaints in the clinic pertaining to the eye would be related to headache. So you can ask the patient if it's one-sided or bilateral. Usually, if it's the classic migraine, it's usually one-sided or unilateral. So is it steady or throbbing? You ask the patient to the area of pain or discomfort, and then you also ask, no, is it something new and acute or something chronic and recurring? So if it's acute and recurring, usually that's very typical of migraine. And usually if it's a classic migraine, the patient will report also some associated symptoms, no? If it's chronic and if it's chronic, you can think about what else? You can think about intracranial masses, no? If it's something very, very acute and sudden, you can think about sudden severe and very acute. You can think about acute hemorrhagic stroke, no? So these are some examples. Was there a recent change in pattern, or is it progressively severe? Is it the same time every day? And then as I mentioned earlier, you ask for associated symptoms because it can point you towards what the cause of the headache may be. So usually if it's migraine, if it's a classic migraine, it's usually accompanied by an aura. Patients will complain of photophobia, no? Photophobia, they don't want to see light, they don't want to hear anything, they just want everything to be dark and silent because that's your migraine. Usually, even if you sleep, even if you rest, the migraine stays there, no, until it wants to go away on its own. And then nausea and vomiting, sometimes if there's a space occupying lesion that increases your intracranial pressure, you can have nausea, you can have vomiting, no, such as in cases of hemorrhagic bleeds. Neurologic symptoms is very important. No? If you see some neurologic deficits like weakness, sensory deficits, no, cranial nerve defects, then that's a red flag. No, you have to investigate further. No, any changes in vision or motor sensory deficit. You can also ask patients if the headache is more severe when coughing, sneezing, or changing the position of the head. So sometimes it can point to, let's say, a sinusitis. No, you can also palpate here, no, to see if there's tenderness. So that could point to sinusitis also. You can also about family history, no, that especially if the patient has family history of, let's say, brain cancer or any cancer, no, that can be a red flag to have further investigation. When you take the health history of the eyes, these are the common questions. You can ask broad questions first or open-ended questions first, like how's your vision, no? Kamusta po yung paningin ninyo? Nagkakaroon po ba kayo ng problema sa inyong mata? Kung meron, tanungin nyo sila, bago lang po ba yan? Or dati na po, napalala lang po ng palala? Gaano katagal na po? Tapos, meron po bang parte ng paningin nyo po na parang madilim, parang may kortina sa gilid, no? Pag naglalakad po ba kayo, paminsan-minsan po ba, bigla na lang po kayong tumatama sa pader, no? So, usually that can signify visual field defect, no? Sometimes you can also ask patients if there are any specks in the areas where the patient cannot see, no? So there's a spot there that's blind, no? That can signal a scotoma. Or does the patient have any floaters, no? If they see lights flashing across the field of vision. So that can give you clues on what the patient actually has. You also ask about pain, redness. No? In your book, there is a list of potential causes of a red eye. So you look that up, no? At the back section of the chapter. You can ask about excessive tearing or watering. Sometimes in allergic conjunctivitis, you can have itchiness. You can also have, in dry eyes, you can have excessive tearing. And of course, diplopia, very common in children. So how do we examine patients with in the head and in the eye? So I'll talk briefly about the techniques of examination. So for the head, first, mostly with the head, all you have to do really is to have inspection and a little bit of palpation. So you examine the hair, look at the quantity, the distribution, the texture, the pattern of hair loss. Usually, if the hair is fine, it's usually hyperthyroid. Those are nice clues, no? Very subtle clues. No, you don't even have to touch the patient and you can actually see the patient may be hyperthyroid. Those with coarse hair could be hypothyroid. Of course, you have to correlate it with the patient's history as well. You inspect also for the presence of nits or lice, especially in school-age children. Male pattern balding. In the scalp, look for scaliness, lumps, nevi, or other lesions. Sometimes you can have a mass there, no? Or scars, no? I'll show you some pictures later. There are redness and scaling in seborrheic dermatitis. You can have scaling also with psoriasis, no? In the skull, look for deformities, depressions, lumps, or tenderness. So in a child with an enlarged skull, that could be hydrocephalus. You can have also bone deformities in Paget's disease, no? And you can also have tenderness, no? If the patient has experienced recent head trauma. In the face, look at the facial expression, the affect of the patient, the contours of the face. Is there any asymmetry? Usually that can point to a stroke or a Bell's palsy, any involuntary movements like tics, edema, no? Facial edema can point to nephrotic syndrome, and any masses, no? Let's say you have mumps parotitis here or a salivary gland tumor, and also some fasces, no? You can have some cleft palate here also. The skin, look at the color, pigmentation, texture, thickness, hair distribution. No? The most common would be acne in many adolescents and hirsutism. So I'll show you some pictures. This is the usual male pattern baldness. No? It starts from here towards here. No? Just imagine Prince William. That's male pattern baldness. So if you have a male pattern baldness in a female, that's abnormal. You can have a testosterone secreting tumor. That's a possibility. So this is alopecia in lupus. So it's diffuse alopecia. If it's alopecia areata, it's patchy. No? In the scalp, you can have redness, no? Here, in the interface of your hair and your forehead, that's seborrheic dermatitis, usually exacerbated by exposure to sunlight, photosensitivity. There. This is your hydrocephalus, no? Hydrocephalus, so your skull deformity. And this is what I was telling about hirsutism. No? This is a female patient, and the female patient shouldn't have some remnants of beard in this area, but this patient has, no? And that needs further evaluation, no? Some patients with PCOS or congenital adrenal hyperplasia or any virilizing tumors can have presence of hirsutism. Remember that character in the movie, I forgot the movie, the musical where there is Hugh Jackman, no, remember one of the characters with very thick hair, but she's a female. That's excessive, no? That's an extreme form of hirsutism. This is also a form of hirsutism, no? You have thick, um, thick mustache, no? And also there's more hair here. That's also hirsutism. And also you also have acne in the face, no? That's very, some patients are not just called balbon, but you can actually score this patient. It's called a Ferryman-Galloway score. You can score the patients for hirsutism. And any high score can point to either the things that I mentioned earlier, PCOS, or some virilizing tumors, or a congenital adrenal hyperplasia. For the eyes, these are usually the things that we examine, no? First, your visual acuity, your visual fields, your conjunctiva and sclera, and then your retina. No? Usually the retina and the retinal vessels we are able to examine using fundoscopy. But I think, again, as I mentioned, it will be discussed with you by the ophthalmology group. No, I think they're the better experts on that. And then you also examine the cornea, the lens, and of course your pupils, very easy to examine, and your extraocular movement. So in the fundus exam, you will see, again, your retina, retinal vessels, the optic disc, and then the macula. And then also the aqueous humor, you can also see there. No? So in the eye examination, of course, you inspect first the eyelids, the conjunctiva, the iris, the cornea, the pupils, no? The movements, no? When you inspect, no, what are the things that we inspect? The position and the alignment of the eyes without doing anything, no? Sometimes, when the patient comes into the clinic, you can also already see diplopia, the eyebrows, if there is any external thinning of the eyebrows, especially in hypothyroidism, you can have like a bald spot here in the lateral aspect of your eyebrows. The eyelids also, you can have like mga hordeolum, what's the other one? Little masses, no, in your eyelids, no? And also the lacrimal apparatus. In the visual acuity, no, we usually express this by two numbers, no? I think you're also familiar with this, no? 20/20. 20/20 is the perfect vision, no? A very unlucky number for us, but 20/20 is the perfect vision. But these two numbers actually represent something, no? So the number above, no, is the distance of the patient from the chart when you examine the patient, during your examination. And the number below will be the distance at which a normal eye, no, can read a line of letters, no? So you have a Snellen chart here, and then you ask the patient to read. Now you position the patient 20 feet from the Snellen chart, no? And then you test each eye individually. So first, you cover the eye. Actually, the ideal will be not to use the hands, because the patient can sometimes peep in between the fingers. So you should actually use an occluder, no? There is actually a wooden thing. I don't have it at home, but there's an occluder, no? Usually in the clinic it's like that, with a handle here. So you occlude one eye, no? And then you ask the patient to read from top to bottom. And then you determine the smallest line of print from which the patient can identify more than half of the letters. And in that line, there is an indication in the Snellen chart what's the visual acuity of the patient, no? So the distance over the lowest line. So if you have a small room, no, you can actually use a mirror on the opposite side of the room. Divide the distance into two. This picture kasi is British, so if it's British, they use meters, so it's 6 meters, no? So you can position the patient 3 meters from the mirror, and then the mirror will be 3 meters from the Snellen chart. So that's equal to 6 meters or 20 feet, no? And then if the vision is not 20/20, you can use pinholes. No, pinholes, let's say, this is usually there's a pinhole in the clinic, and there's a small hole here, and the patient will read will read the Snellen chart through that small pinhole. If the vision is corrected, meaning the patient can read from top to the bottom, then it means that the patient has an error of refraction. If the vision is corrected using a pinhole, then that's an error of refraction. You'll be able to practice that when you rotate in ophthalmology. So if the patient cannot read the top line or the biggest letter from 20 feet, you move the patient nearer, no, at 10 feet, and then closer and closer. If the patient is, and then you change the visual acuity, no, 10 over 200. So if the visual acuity number, if the number below is big, it means that the vision is worse. The bigger the number in the bottom number, the worse the vision is. No? So if the patient still cannot see the biggest letter, no, even if you move the patient closer, so this usually happens in patients with severe visual problems, no, you can do counting fingers, no, you test one eye after the other, no, you test each eye individually, and you ask the patient if they can count 2, 3, 5, no, 1, 2, okay? If the patient still cannot see the counting fingers, then you ask for hand movement. So here, can you see that? Can you see that? Doctor, I can see that. If the patient still cannot see the hand movement, then you do light perception. No? So you just cover and then you shine a light, no? And and the patient can see light perception. So the visual field is, when you report it, the visual acuity is just light perception. No? If it's hand movement, visual acuity, hand movement only, or counting fingers. No? So that's it. Sometimes if the Snellen chart is not available, you can use a handheld Jaeger chart to test for vision also. That's a very handy chart that you can put in your pocket. No? You can also test for near vision. Usually you identify the need for reading glasses or bifocals in patients using also this Jaeger chart. And then the Jaeger chart, when you check for visual acuity at bedside, no, you can bring the patient to the clinic. You hold the Jaeger chart 14 inches from the patient's eyes, okay? And then if you don't have anything, you don't have a Snellen, you don't have a Jaeger chart, you just get like a book or a newspaper, and then you ask the patient to read for you, okay? So that's a crude way of checking for visual acuity. So this is checking for using your Jaeger chart. And again, 14 inches, no, from the patient's nose, check each eye individually. Ideally, you use an occluder, not the hands, no? Maybe a card or a paper. So error of refraction, if your vision is normal, you can see all of them, not both balls and both boys. So this is emetropia, that's normal. If your eyeballs are prolonged and the visual field does not hit your fundus, no, you can have myopia or nearsightedness. You can see the near objects but not the far objects, and vice versa. If it's hyperopia, I don't have a picture for hyperopia. The focal point will fall behind the eye, and you can see the boys, but you cannot see the balls. Okay. Next, we look at So next we look at the visual fields, no? So the visual fields we test by confrontation testing, no? So field defects, usually we imagine the head of the patient is covered by a big, let's say, big fishbowl. And then you test the visual fields based on the fishbowl, no? So you can test with both eyes open at the same time and test. No? So like that. Can you see that? Like that, like that, like that. If there's a defect, then you test each eye individually. No? So if there is, the patient cannot see, let's say, you test individually, the patient cannot see from the lateral to the midline, then you can have hemianopsia. Now, if both eyes have a defect like this, no, that's your bitemporal hemianopsia. If the, this is homonymous hemianopsia. If the defect is on both the temporal sides, no, that's your bitemporal hemianopsia. Usually, that signifies a lesion occluding your optic tract, usually from cellar mass. No? And sometimes you can have quadrantic defects. A particular quadrant is have a visual field defect. No? So as I mentioned earlier, if there's a defect, you ask the patient to cover one eye, no? Cover opposite of your eye, and ask the patient to look ahead, and then move the hand until the patient will point if she is already seeing the hand or the finger within her field of vision. Okay? Later, I'll show you a video. Okay, so at first you check both eyes simultaneously and then individually. Okay, that's it. That's your confrontation testing to check for visual field defects. Next, you also should inspect the conjunctiva and sclera. So this is your normal. No, the sclera usually whitish. No, the conjunctiva is usually whitish, and the sclera is usually pink. No, if the sclera is yellowish, then that indicates jaundice. No, but sometimes if the sclera is dirty, you're not sure if it's really icteric or not, you can actually test the mucosa underneath your tongue to verify whether this patient has really jaundice or not. If you're not sure, by checking at the sclera. Usually you inspect here. Okay, if you're not sure. Next, you can also check for pallor in your palpebral conjunctiva. Normally it's pink. If it's pale, that can signify anemia. Next, you inspect the pupils. Inspect the size, shape, and symmetry. If it's large, more than 5 millimeter or small. Usually, in your Jaeger chart, there's a pupillary size there. You can actually measure your pupils against that Jaeger chart based on this figure. No? If it's unequal, that's called your anisocoria. Okay, so there are many things that can cause anisocoria. Lastly, we will show you how to test. I think I briefly described this earlier, no? How to test for pupillary light response. No? So you shine a light in your pupil from the side, no? Like that. Okay, observe the reflection of the pen light in both pupils. You shine a light here, and then you see the reflection on the eye. You see that reflection. It should be symmetrical. If it's not symmetrical, the patient can have diplopia. And then next, you check for pupillary response to light. So the one that I discussed earlier, you shine a light in one eye, you check the pupillary light constriction, and then you shine it again, but this time looking at the other eye to see if the pupils are constricting. So they should be both constricting. So you shine the light 2 times. First to check for direct response, and the next to check for consensual. And then you check the contralateral side as well. Okay? And then lastly, your extraocular muscles, no? The cover, uncover test. So the cover, uncover test, no? Usually when you cover one eye, some patients will, when the eyes are not covered, no, the eyes are okay. You cover one eye, sometimes the diplopia, no, will now be manifested by the patient. So that's your cover uncover test, no? So the diplopia, not diplopia, the abnormal extraocular defect, no, will only be manifested if you cover. Okay, and when you test the extraocular muscles, of course, we perform the conjugate movements of the eye, and you also test for nystagmus. So how do we test for nystagmus? So usually we ask the patient to look at the finger and then look towards the rightmost, and then you observe the eye movement. Now, if you see fine, sorry, you ask the patient to look at the rightmost like that, and then look closely at the eye if there are any fine rhythmic oscillations of the eyes, no? Usually the eyes will move like that. That's your nystagmus. And then you also test the other side. And then look closely if there are, again, fine oscillations on the other side of that, in the eyeballs. Okay? So how do we test for extraocular movements? No, you ask the patient to hold his or her head still, like that, no? Not like that. Okay, so the head should be steady, and then you make a big H, no? You ask the patient to follow your finger, no? And make an H figure. So to the left, up, down, to the other side, up, down, okay? And then observe the movement of the eyes if it's conjugate, okay? So you just imagine a big H. So right now, I'm not making a big H because I want you to see it within my screen. But normally, you do like that, big ones, okay? And then, so look at, you should be able to cover all the 6 cardinal positions of gaze, okay? And then, I think this is the second to the last. You can also observe for lid lag. Lid lag is very important when you are suspecting any patient with hyperthyroidism. Some patients will not have exophthalmos, no, but they will have lid lag. So how does this happen? You ask the patient to move, to follow your eye, look down like that, no? Normally, the upper eyelid should cover part of the iris. But if there is lid lag, no, the eyeball is already looking downwards, but the lid has lagged behind, no, and is unable to cover the iris. So that's your lid lag. That's usually observed in patients with hyperthyroidism. And then lastly, your convergence, no? I think I mentioned this earlier also. You ask the patient to follow your finger or pencil as you move it towards the bridge of their nose, and the eye should normally be able to converge, no? And follow the object between 5 to 8 centimeters from the nose, so like that. If only one of the eyes is moving, then there's a problem with the extraocular muscle on the contralateral eye, and vice versa, no? So sometimes only one eye can move in, but the other eye cannot move and converge to the medial side. All right, that's it. So I'll show you the video on, I'll upload also this video in Canva so you can see it. Because I think my free Zoom video recording is running out. So I'll show you this on a separate video. I'll upload it in Canvas as well. So I hope you learned something today. So my reminder for you guys is to read your baits and make sure you read the red ones, the pathologic findings that you see with each physical examination, and also review the back section of that chapter for the details on the different pathologic physical findings. No, I'll leave it up to you to read that, and then just follow this video so that you will be able to perform your own vlog as well. Okay? So I'll see you on the next video with this video. And I'll give the summary towards the end also. Okay. I think I'm still okay. So we will just play this. Let's see if I'm able to finish.
This video presents examination of the head, including inspection of the head, hair, scalp, skull, and face. Examination of the eyes, including tests for visual acuity and visual fields, inspection of the eyes, and ophthalmoscopic examination. And examination of the ears, including inspection of the ears, otoscopic examination, and tests for hearing. In this video, the examiner will assess a healthy patient. Keep in mind that other patients may have the same normal findings or may exhibit normal variations or abnormal findings. Begin your examination with inspection of the head. Observe the size, shape, and position of the head, as well as its proportion to the neck and the rest of the body. Inspect the hair, noting its quantity, texture, distribution, and pattern of loss, if any. Part the hair in several areas to inspect the scalp.
Have you noticed any problems?
Observe for scaling, lumps, lesions, scars, and nits, or lice eggs, which are tiny white ovoid granules that adhere to hairs. Palpate the scalp and skull for masses and tenderness. When examining the patient's face, observe it at rest and during conversation. Also, assess the color and condition of the skin on the face. Look for skin lesions, scars, masses, edema, and unusual pigmentation for facial hair. Begin the eye examination by assessing the patient's visual acuity. This, have the patient stand 20 feet from a Snellen eye chart. If the patient wears contact lenses or general-purpose glasses, tell her to wear them. But ask the patient to remove reading glasses because they blur distance vision.
F, E,
Note the visual acuity
L,
printed at the side of the line of the eye chart.
D, Z, and D. Now I'd like you to try to read the next line. D, F.
Then repeat the test on the other eye. Remember
D,
to record visual acuity using two numbers, such as 20/20, which is normal.
E, and F.
Now prepare to test the patient's visual fields. Directly face the patient from a comfortable distance and imagine a glass bowl encircling the patient's head. Ask the patient to look into your eyes. As you return her gaze, place your hands 2 feet apart lateral to the patient's ears. Then, at ear level, move your wiggling fingers along the imaginary bowl until the patient points to them. Repeat these movements in the upper and lower temporal quadrants. Normally, a patient sees both sets of fingers at the same time. If so, the visual fields are usually normal. Note that the eyebrows normally limit the visual fields in the upper temporal quadrants compared to the lower temporal quadrants and the directly lateral areas. During the eye inspection, observe the alignment and symmetry of the eyes. Also, examine the eyebrows and closely inspect the eyelids. Normally, the upper eyelid covers a portion of the iris, but does not overlap the pupil. Inspect the area over the lacrimal gland and lacrimal sac for swelling. To inspect the conjunctiva and sclera, ask the patient to look up as you depress the lower lids with your thumbs. Normally, the palpebral conjunctiva is pink and uncongested. The bulbar conjunctiva is transparent with vessels running through it, and the underlying sclera is white. With oblique lighting, inspect each cornea and lens for opacities. To do this, shine a pen light from the side toward the eye. You should see no opacities. Even without side lighting, you may notice a corneal arcus in an older patient. This normal variation is a white ring around the periphery of the cornea. Carefully inspect each iris and pupil. Normally, iris markings are clearly defined, and the pupils are round and equal in size.
Just look straight ahead and into the distance.
Continue assessing the pupils by checking their reaction to light. Observing one eye at a time, ask the patient to look into the distance. Then, from the side, shine a bright light into one eye and observe its pupillary response. The pupil should constrict briskly in direct reaction to the light. Now shine the light into the same eye again, but observe the pupillary reaction of the opposite pupil. It should constrict briskly in a consensual response. Repeat the process with the other eye. Watch for direct and consensual pupillary reactions again. If the pupillary light reaction is abnormal or questionable, test the near reaction. Hold your finger or a pencil about 10 centimeters from the patient's eyes and tell her what to do. Watch for pupillary dilation with distant gaze and pupillary constriction with near effort. Repeat this test if necessary, and then repeat it in the other eye. To assess the extraocular muscles, shine a light onto the patient's eyes from about 2 feet away. Ask her to look at the light. From just behind your light, observe its reflections. These should be visible slightly nasal to the center of the pupils. Now check the 6 cardinal directions of gaze. These directions correspond to the coordinated action of 6 muscles involved in eye movement, innervated by cranial nerves 3, 4, and 6. From 2 to 3 feet in front of the patient, ask the patient to follow your finger. Making a wide H in the air, lead the patient's gaze to the patient's far right, to the right and up, to the right and down, and without pausing in the middle, to the far left, to the left and up, and finally to the left and down. Eye movements should be symmetrical and conjugate. To detect nystagmus, pause during upward and lateral gaze. A few beats of nystagmus on extreme lateral gaze are normal. In a patient with lid lag, watch for a rim of sclera between the upper lid and iris as the eyes move up and down. To test for convergence, observe as the patient's eyes watch your finger move toward the bridge of the nose. Normally, the eyes converge and follow your finger to within 5 to 8 centimeters of the nose. When you're ready to examine the fundus, switch on the ophthalmoscope light and adjust it to the large round beam of white light. Also, make sure the light...
Okay, so I will end the video here because we will leave the fundoscopic examination to our ophthalmology colleagues. So we don't expect you to do the fundoscopy during your vlogs, but hopefully you will be able to perform your vlogs following this video because this video is exactly an accompaniment of your beat. So everything that you need here to be checked is already here in this video. Okay, so practice, and then good luck on your vlog. So I'm sure you'll do great. And don't forget to read again your beats. Okay, bye-bye and have a good morning.